Among the diagnostic tests available to the nephrologist, at the moment the most important one is still kidney biopsy. Among the most common indications that are taken into account to carry out renal biopsy, nephrotic syndrome is certainly the most common, followed by acute renal failure, renal involvement in course of systemic diseases, and finally dysfunction of transplanted kidney. Before proceeding with the renal biopsy, the patient should carry out some blood tests, including coagulation and renal imaging, in particular renal ultrasound, in order to identify any contraindications to perform this procedure. Once the previous investigations have been performed, the patient is prone. The lower pole of the left kidney for the native kidney, or the superior pole for the renal transplant, will be identified with the help of the ultrasound. Once the skin has been cleaned with antiseptic, local anesthesia is performed using a fine needle. The local anesthesia is guided to the renal capsule by continuous ultrasound, so that the operator can observe the direction of the needle. Once the local anesthesia is carried out, the next step is renal biopsy. The needle which is generally used is a true-cut needle of variable sizes, the most common being the 16 gauge. The ultrasound probe is covered in a sterile sheath with ultrasound jelly. Ultrasound guides are placed on the probe in order to lead the needle through the path that simultaneously is displayed on the ultrasound monitor. The angle of the guide is set up on the ultrasound before starting the procedure. The needle is introduced through the same path that was used to carry out anesthesia into the renal capsule. The patient is then asked to stop breathing in order to fire the needle into the kidney.
Blocchi il respiro, signora. Ok, ferma così. Ferma.
Once the needle of the kidney biopsy is removed, advancing the central part of the needle reveals the core biopsy. The cores, which are usually obtained after renal biopsy, are about 2 centimeters long. This core must be observed with a stereomicroscope to evaluate its adequacy, which is linked to the presence of glomeruli. Once the adequacy of the core biopsy has been evaluated, it is divided into 3 samples in order to make the correct diagnosis of kidney disease. These procedures are light microscopy, immunofluorescence, and, where possible, electron microscopy. In particular, we always recommend placing a sample of the core biopsy in a fixative suitable for electron microscopy, even in those departments where an electron microscope is not present, so that a subsequent observation can be carried out in another equipped department where this analysis can be performed. Once renal biopsy has been obtained, the skin incision is compressively dressed and the patient is rolled into bed in a supine position for about 24-hour observation. Adequate post-biopsy monitoring includes checking the blood count 3 hours after performing the kidney biopsy, frequent blood pressure checks, especially in the early post-biopsy hours, and an ultrasound that can be carried out the following morning.
Buona